It's okay.
You got it?
I'll just put it there.
Okay, great. Thank you.
Good morning. Can you hear me well? Yes? Okay. So I want to take this opportunity to thank Dr. Pilar and the president of the university, as well as all the organizing committee, because it's a great task to finish from start to finish. I'm here not to define the chemical sensitivity, but to put it together, all different mechanisms. Dr. Pilar has given her incredible lecture preceding me, and I'm just going to put that together so that you can understand and put it in your own rhythm. So in order to define the chemical sensitivity, I want to make sure that we understand that it is an adverse reaction to ambient levels, which is not a toxic level, either to the toxic or non-toxic chemicals, which is contained in the air, food, and water, including the soil, because our soil and our water, they both are contaminated and increasing in the total load. So now let's describe what is the difference between multiple chemical sensitivity and chemical sensitivity, and why I talk about chemical sensitivity and do not use the commonly described word multiple chemical sensitivity, which is described in most of the European world. Initially, the multiple chemical sensitivity was a term which was coined by Dr. Cullen in 1987, who is proponent of the occupational medicine. And according to his criteria, there must be a documented environmental exposure of toxic chemical. And then the symptoms can involve one or multiple organ systems, and these symptoms are induced by chemical below the toxic levels. However, according to his definition, there are no objective findings, and there are no mechanisms that describe the origination of the disease. However, in chemical sensitivity, we don't have a documented history of toxic chemical exposure. There may be at a subtoxic level, there may be also multiple system involvement, there may be one or more. The symptoms can be in one system or multiple organs, but there is objective signs. We do see our patients not having only symptoms, but multiple objective signs, and we do have multiple mechanisms which were discussed yesterday, today, and so I would say that we have a chemical sensitivity more than multiple chemical sensitivity. Now, we know that there's an increasing prevalence of chemical sensitivity in the population. It affects 1/3 of the population and causes the functional disability. There is a lack of understanding of the multiple system physiologic nature involvement. However, there are 5 to 10% of the patient experience the chronic symptoms and functional impairment. So 50 to 70% of these patients, they have a moderate to severe limitations in their daily activities. They are unable to tolerate workplaces, public buildings, and transportation. Not only that, but they have a reduced opportunities for employment. And many of them are socially isolated. And this is a big problem. If you are socially isolated, you are not able to function. So quality of life score is also reduced. And just like the patient suffering from rheumatoid arthritis or asthma, fibromyalgia, or multiple other diseases. And there is a clinical paradox. Patient is suffering from persistent symptoms. However, diagnostic and therapeutic confusions, in spite of symptoms being persistent, involving multiple systems, the routine laboratory testings are normal. Even after doing the extensive diagnostic evaluation, there is no answer. And therefore, they are misclassified as a psychogenic. It has been discussed yesterday, it has been discussed today, and I'm again emphasizing that these patients end up getting the poor treatment because their treatment approaches are inconsistent, they are unrecognized, they are maladaptive, and so the medication trials have minimal effect in a conventional medicine. And thus, the healthcare dollars are utilized in a wrong direction. Patients continue to have complaints, and sick one is getting sicker, and confusion exists. So, in summary, current care pathways remain ineffective because the underlying physiology is misunderstood. So now let's look at the total body burden and how the body moves from homeostasis to dyshomeostasis. As you see here, this is the barrel. Sorry. This is the barrel which you see in the center, and look at the size of the barrel. One may have a large size of the barrel, and one may have a very small size of the barrel. And that determines who is going to be more affected, because the total noxious stimuli from air, food, and water are handled and fill up this barrel. And not only that, but these pollutants can be outdoor, indoor, as what Dr. Pilar showed you before. There can be electromagnetic radiation and radon gases, as well as the man-made chemicals, biological chemicals, natural chemicals, including the infection. So these all exposures converge into cumulative physiologic burden. And when it exceeds the adaptive capacity, there is a loss of homeostasis. So there is a synthetic chemical exposures, which can be air pollutants, solvents, pesticides, formaldehyde, water contaminants. There can be biological toxins, as described previously, mold and mycotoxins. Yesterday it was described also as a Lyme, and chronic infections, persistent immune activation, electromagnetic radiation, and electromagnetic field sensitivity or electric hypersensitivity, temperature irregularities, indoor air contaminants, including the biological factors like pollens, molds, foods, parasites, and specific environmental load. And these all end up causing the persistent immune activation, oxidative stress, and metabolic dysfunction. So the state of health depends upon the food, chemicals, and inhalants, including infections, emotional upheavals. Patient may be completely normal, but if there is a certain grief reaction from the death in the family or a divorce or similar nature, electromagnetic field, and poor nutrition, and genetic also plays a part. So when total load increases, there is an elevated cumulative burden, which leads to the homeostatic instability. And increased total body burden results into the impaired adaptive regulation and multi-system dysfunction. So chemical sensitivity is not structural tissue injury, neither psychogenic in origin, but it reflects the disorder of homeostasis. It is not an IgE-mediated allergic disorder. It is not an acute toxic poisoning, or it's not a primary psychiatric illness. So now let's look at how the body tries to adapt to the increasing amount of total toxic burden from the environment. So you see phase A, unfortunately. This is the phase A, which has a normal steady state. There are no symptoms, and they are under baseline conditions. And when there is some pollutant exposure, there is an alarm reaction. However, the body comes back to normal. But when there is an increasing amount of noxious stimuli, which comes one after another, the body goes in a phase B, which is the adaptation to the increasing load, and repeated compensatory responses occur. In this new state of adaptation, which in an earlier phase it not masked, but in later phase it is masked, and one may have symptoms. In early phase, did not have symptoms. During this phase, there is an increased upregulation in metabolism, there is immune activation, and there is also upregulation of detox enzymes. So body has a capacity to increase or decrease depending upon the needs what one has to detoxify. And when the detoxification increases, there is an increased utilization of nutrients. And discuss, you may have an increased utilization of like vitamin B6, B12, magnesium, selenium, zinc, etc. And so it results into the new adaptive stage. Now, if these chronic noxious stimuli become persistent, then you enter the phase of maladaptation. So increasing total load initially produces the adaptation, but sustained burden leads to maladaptation and loss of regulatory resilience. So the body has a way of adapt, but during that phase of adaptation, it may spread to the different organs. It may start in brain, then it may go in liver, it may go in kidney, or it may be sensitive to one chemical initially, like one may be sensitive to formaldehyde. Then as it continues, then one may become sensitive to similar substances like glutaraldehyde, acetaldehyde. But then body loses the phase of adaptation, and it start becoming sensitive to the multiple different chemicals like ethanol, all organophosphates, or tetrachloroethylene. And so what begins as a specific exposure response evolves into the multiple system and multiple trigger sensitivity. So spreading reflects the progressive dysregulation of adaptive buffering system, leading to broader physiologic reactivity. So one may develop spreading response. One may also develop the switching phenomena. And remember, this is very important because this is the reason when our patients are complaining, one time my head hurts, one time my stomach hurts, and all different complaints, the traditional physician is only trained to think conventionally. They have algorithm, and when it falls outside of that, it doesn't belong to the structural disease, and then it becomes psychogenic. So we have to understand when patient complains, is this patient in spreading phenomena? Is this patient in adaptation? Is this patient is developing the switch phenomena? And what happens in switch phenomena? Target organ response may switch to many different organs during same 24 hours. In the morning says, oh, I can't think, or they may have symptoms of brain dysfunction. Then later on in the day say, oh, my body hurts. Oh, I am having fatigue. Oh, I'm having diarrhea. Oh, I am having palpitation, anxiety, crying spells. So during this switching, there is a dynamic regulatory instability, and there is no separate unrelated disease. And the same exposure can produce different organ expression at different time. And same patient may, one time may suffer from brain fog, and next time may suffer from anxiety, or it may be a continuum. Then we have to remember each individual is not the same. Each individual has a unique biological profile, and that's why they are biological different. Now you see here in panel D, down here, look at that. That person has a full deck of all the systems, including the immune function, enzyme activity, minerals, vitamins, proteins, lipids, and carbohydrate, versus this patient in a panel A. Look about, they have a poor immune system, poor detox enzyme system, and they are low in their vitamins and minerals, low in proteins. So this person is the perfect individual who's going to develop the disease process. When we are saying that in the same room 10 people are there, why 2 people end up getting the problem and 8 are okay? And because their ability to handle this total body burden is reduced. So when there is an excessive amount of chemical exposure, there may be a depletion of vitamins, minerals, amino acids, and lipids. And an individual becomes the depleted individual. And then what happens? They have a functional deficiency of their enzymes. They are given normal. They were born with the normal amount, but their function is reduced. And what happens when the function is reduced for the detox enzymes? There's an accumulation of total toxic load. And so that's how the sick one gets sicker. Now let's look at the genetic susceptibility. There are about 3,000 metabolic disorders. And polymorphisms, like yesterday, our colleague described that there can be a problem with the MTHFR, with this polymorphism, and there may be a deficiency, relative deficiency of B12 and folate. There can be problem with the polymorphism of catecholamine O methyltransferase COMT enzyme, and these are very common in our chemically sensitive individuals, which may initially develop chemical sensitivity or may have a problem with mole mycotoxin, have Lyme disease, Lyme-related problems, or may have many other diseases. So genetic expression generally guides the body's baseline physiologic response, but it doesn't determine that which person is going to have a problem. It is the epigenetics, it is the environmental pollutants which acts as a trigger, and it activates the underlying susceptibilities, allowing the disease to manifest. So in other words, what happens is the genetics is a sitting time bomb, but the epigenetics or the excessive amount of environment pollutants acts as a trigger, and it pulls the trigger, and then the bomb explodes. Okay, so in summary, what I described is that when the size of the barrel determines who is going to be sick. Now, how, when there is an increased amount of total environmental pollutant, one may adapt. One may have a bipolar response, immediately may have a stimulatory response, and later on may have a depressive response, which Dr. Pilar described yesterday very well with the alcoholics, which feels good initially and feels great, and then keeps on drinking, and then they are nowhere to be found. Then it may go into the spreading phenomena, switching phenomena. Biochemical individuality determines part of the response, and also the specific environmental load must be addressed. And then what happens with the excessive amount of total environmental load? The body goes from homeostasis to dyshomeostasis. So now let's look what is homeostasis and how that spectrum, that pendulum, moves to dyshomeostasis. Now it's very important, it's only one thing I want you to go home, is that to understand what this total ground regulation system is. And as you see that, this ground regulation system is the determined, it maintains the homeostasis. So here, if you see that, this is the ground substance, which is made of proteoglycans and glycans, and they have to be hydrated well. So that was the reason I said that any sick person, when comes to you, make sure they are properly hydrated. In order for the stimuli to go and body to respond properly, this ground substance has to be maintained in a gel-like substance. Then you look at, I'm sorry about, okay, so as you see that these are the blood vessels, and there is a 3 type of cells in this ground matter, and these are the mast cells, these are the mast cells, these are the fibroblasts, and these are the macrophages. And they are very important. Each and every organ of the body has this ground regulation system. And look at the blood vessels, and look at these autonomic nerve fibers, look at the sensory fibers, look at the proximity of the mast cells and the blood vessels, as well as the autonomic nervous system. So the neurovascular proximity activation are very important. Autonomic nerve endings lie within the 0.2 micron of the capillaries and mast cells. So now that explains mast cell activation, that explains why there is an immediate problem with the neurovascular system. So physiologic balance is very dynamic. The regular cell systems fluctuate within a normal physiologic range, and there is a constant kaleidoscopic movement occurs in this ground regulation system, which maintains the homeostasis. And when the adaptive buffering capacity fails, there is a progression of instability and heightened sensitivity to low level of exposures. So low level of ambient level of chemicals, body starts reacting. And then there is a loss of homeostasis. Early clinical manifestation of hemodynamic dysfunction is pain. And you can see that the pain, the sensory fibers, they release substance P, and that's where the pain is derived. One gets fatigue, which is part of the malfunctioning of mitochondria, and the body becomes weak. So these are mainly three manifestations that we look for Does this patient have pain? Does this patient have fatigue? Does this patient have a weakness? And it can be a mental fatigue. It doesn't have to be a physical fatigue. Or it may be a fatigue in any of their biochemical processes. So what happens when most of the triggering exposures are volatile? They enter through the olfactory and trigeminal nerve endings, and it goes through the cribriform plate inside the brain into the olfactory bulb, limbic system, brain system, and autonomic regulatory centers. And like Dr. Pilar described yesterday, that there is a problem with the denervation hypersensitivity. So I want to explain how that happens. These chemicals, when they try to enter through the nose into the system, they get sequestered during their transit into these nerve fibers. And so the fibers which are distal become hypersensitivity. So it may be the limbic system become hypersensitivity. It may be the brainstem become hypersensitivity. And then the body starts reacting at a lower level. And so the unmyelinated neurons transmit the signals within seconds. So the patient comes and smells something and immediately starts developing symptoms. And this is why they think it is psychogenic, but it's not. This explains that how it happens. So then there is a neurovascular coupling happens, change in the vascular tone, endothelial signaling, nitric oxide dynamics, and that's where Dr. Martin Paul's no cycle comes in. And then there is derangement in the extracellular matrix. I can take the whole 1 hour lecture on that ground regulation system. I have just touched enough for you to understand what goes there. So the clinical consequences occurs, there is a failure of early containment and localized neurological event. It goes into the progressive multi-system dysregulation. And at this stage, chemical sensitivity is no longer an isolated exposure response. It evolves into the self-amplifying multi-system disorder where the secondary amplification system comes into the picture, neuroimmune endocrine system gets activated, vascular and cardiovascular system gets activated, dysfunction in neurological system manifests as a central peripheral limbic or autonomic nervous system dysfunction, leading into common complaints like insomnia, anxiety and depression, and cognitive dysfunction. And so there is a multi-system dysfunction. And as shown here, the limbic system and hippocampus where the mood and memory is there, amygdala where there is a panic response, hypothalamus is affected where there is a HPA axis response. So one may have emotional disturbance, one may get the ADHD kind of activity where one is very hyper, not having focusing, not having concentration, not having attention. And then there is a problem in the executive functioning. The person who was right here, it seems like it's cluttered. And then poor motivation and autonomic nervous system, which becomes completely deranged. Also, there is an immune dysfunction, infection susceptibility, and that is an autoimmune shift, where yesterday Dr. Pal showed it very beautifully, that how the adaptive immunity gets affected, and then that CD4 system becomes the Th1 dominant system, becomes the polarized into the Th2 system, and if there's and one may develop the allergy type of responses. If there's a failure of Treg system, one develops the autoimmune diseases, and so on. And then there is the hormonal dysfunction, where there is HPA axis dysregulation, and there is a vascular dyshomeostasis, where there is an altered blood flow, microcirculation gets affected, and brain functioning goes down, and there is the inflammatory cascade is triggered. So again, this shows the same secondary amplification system augmentation. And so when there is excess total body load and pollutant load and nutrient deficiency, which may be primary or secondary from overutilization, from adaptation, one develops the inflammation. So no matter what we are talking, inflammation is at the center stage of this disease, and it may manifest as a hypersensitivity or chronic degenerative disease or combined hypersensitivity, where one may develop the degenerative disc disease or joint disease, and finally one may develop the fixed name disease like kidney failure or chronic heart disease or chronic vascular disease. And so now let's look at the mechanisms. Claudia Miller, who is the professor of immunology at University of Texas, she has described chemical sensitivity as altered physiologic responsiveness, not from tissue damage. And what she emphasized that prior exposures contribute to that sensitization. And this sensitization results into the repeated or intense exposures leading into neural and regulatory sensitization, and that results into the lower activation threshold, and which is amplified as a multi-system response. So in summary, prior exposures are essential to contribute to sensitization. And once the sensitization occurs, there is the lower future exposure threshold. And this low-level exposure can keep on reproducing symptoms as it is shown there as a normal, slow recovery and amplified response. So chemical sensitivity represents the disorder of homeostasis, and it is explained here that it is not a classic toxic tissue injury, it is not dose-dependent tissue response, and it is explained by the multiple organ disease. So here doses are far below toxic thresholds, multiple organ system involvement occurs, and symptom patterns show internal consistency. Now it is important to understand this toxic dose response because most of our patients do not have a toxic dose response. The range of increasing effect with increasing dose. However, in our chemical sensitive patient, they have a hormetic response. And as you see here, there is a biphasic mode, and this is the low dose inhibition, high dose have a stimulation. And here there's a low dose stimulation and a high dose inhibition. And in our chemical sensitive patients, we see this hormetic response. And that is what yesterday when Dr. Monroe described in the provocation neutralization technique and how she was able to neutralize the patient's symptoms using the different molecules, including the neurotransmitters. In many of our patients, we use the PN technique for histamine, serotonin, acetylcholine, norepinephrine, and epinephrine. And many times, 30% to 40% of our patients become really stabilized along with the 5 different methods that I discussed yesterday. So then Dr. Iris Bell also described this neural sensitization model, and in that she emphasized that chemical sensitivity results from neural sensitization. Repeated or intense exposure lead to amplified central nervous system response. And in these, the limbic system hyperresponsiveness to chemical triggers are very important. And lower activation threshold, exaggerated autonomic and neuroimmune response, and cross-sensitization too between chemical foods stress and other triggers. In our experience, we have seen 85% of chemical sensitive patients are sensitive to food, and 85% of food sensitive patients are sensitive to chemicals. So there is a real synergy occurs there. And this is where it shows that initiation occurs through the olfactory and trigeminal system. Following the initiation, then there's a core mechanism where there's a lower activation threshold, glutamate and GABA inhibition, and amplification occurs when autonomic system is amplified. One develops PARTS, palpitations, temperature dysregulation. With immune system activation, there is a mast cell activation, and large number of our patients are experiencing the mast cell activation. And cytokine amplification, loss of tolerance, HPA axis dysregulation, adrenal insufficiency, thyroid disruptions, endothelial activation, nitric oxide shapes ono cycle, perpetuates that, and extracellular matrix signaling, which then the homeostasis pendulum moves towards the dyshomeostasis. So in summary, you need to have a prior exposure resulting into the neural sensitization, lower activation threshold, and the symptoms even at a low level exposure, and then it results into the persistent dysregulated responsiveness. And one important thing to remember that when the exposure stops, symptoms do not stop. It just continues. And one may say that you are not exposed to anything. It takes about 4 to 7 days for one to completely de-adapt and come back to the normal physiologic state. If they are into the irreversible, from irreversible to reversible phase, that's very important thing. So chemical sensitivity cannot be explained by traditional toxicology models. It is an altered physiologic responsiveness. It's not a toxic injury. And one more thing I want to emphasize is there is a female predominance. Remember that, because 60 to 80% of your patients are going to be female, and 70% of them suffer from PARTS, which is the autonomic dysfunction, and 75% of women have a mast cell activation syndrome, and so they have a multiple different symptoms which are related to the histamine or serotonin, and so on. And 60 to 80% of women, those who are suffering from autoimmune diseases. So how is it that the female are so predominant? Because the estrogen affects the immune system and autonomic nervous system. It narrows the tolerance windows, and estrogen modulates immune system, autonomic nervous system, detoxification pathways, and so these are the reasons that female are very specifically susceptible, and they have a reduced phase 1 and phase 2 enzyme system. In certain number, glutathione and methylation are affected, and they are higher fat soluble, and knowing that female, because of their curvature, they do have a higher amount of fat. So in conclusion, comprehensive understanding of the principles of central nervous system sensitization is essential to avoid rigid, fixed disease. As I explained into the model of adaptation, it is irreversible even when there is a phase B, but it becomes much more irreversible when you go in phase D of maladaptation. So what is our responsibility as a physician? That we have to recognize the early neurovascular effects, lowered extracellular matrix thresholds, mast cell activation, and autonomic dysregulation. When we see these, we know that this person still is in a phase that is reversible. And so if we do the timely intervention at this phase, we can prevent the progression of the disease. Without timely intervention, it will continue to progress. There will be a central amplification, and neuroimmune endocrine vascular feedback loop becomes self-sustaining, and it perpetuates. And this pendulum then goes to all the way to the extreme condition, and it becomes irreversible. When it becomes irreversible, it goes to the fixed name disease. Like you have a kidney failure, you are suffering from an irreversible heart disease, or you have a diabetes mellitus, and so on. So this progression often results into the fixed diagnostic disease, multi-system disorder with significant and lasting impairment. So chemical sensitivity is a rapid biologically driven disorder of regulation. It is not a toxicity, it is not a psychology, it is, we understand that it is the physiologic maladaptation, it can be reversible, but the only problem is that we have waited in this understanding, we have not educated larger number of physicians, and as a result, the patients are being treated with all different modalities which don't help, and health forecast keeps on going up through the roof, and our sick patients are getting sicker. So I'm so glad that in this part of the world, Dr. Pilar has started a real change in approach, how to approach the patient. And it is a movement. Don't think it is just related to Spain. It's going to move. And it is responsibility of every physician who is here that to spread. And you start the small group, and your patients are going to help you. So thank you. This just shows you the complete model of integrated disease. And these are the 5 books that you can learn a lot. And if you would like, you can contact me. It's my dear friend, Dr. Ray, and I, we have written it together. And unfortunately, he's no longer with us, but he is here. He is here, and the pillar is here.